Hi guys, so this is part 2 of the thorax and lung examination. So for part 1, I've discussed the inspection, palpation, and percussion of the posterior chest. And in this video, I wanna finish it off by discussing the auscultation of the posterior chest and the anterior examination of the chest as well. So when auscultating the posterior chest, we use the diaphragm of our stethoscope and we place it directly on the patient's skin. We don't place it over clothing because this introduces friction and this might add some abnormal sounding sounds. And we also ask the patient to, take a deep breath and breathe out with their mouths open. Again, this is to eliminate that risk of breathing in and out through an obstructed nose, which would then introduce abnormal sounds as well. What we actually do is we follow that same ladder pattern that we do for percussion when we're doing auscultation. So we place the diaphragm of our stethoscope onto those different positions on the posterior chest and listen for like at least a full breath per location. We're looking specifically for 3 things. So we're looking for any abnormal sounds, we're looking for any adventitious sound or added sounds, and we're looking for, we're noting the intensity because that reflects the flow rate. The normal sound that you should hear like across most of the areas of the lung is called vesicular breath sounds. Vesicular breath sounds are low in pitch, soft, and inspiration is kind of longer than expiration, and you shouldn't hear any gaps between the 2 phases. There are other types of breath sounds like bronchial, bronchovesicular, and tracheal breath sounds. So bronchial is when inspiration is shorter than expiration, and there is a definite gap between the 2 phases. And with bronchovesicular, inspiration almost equals the time that it takes for expiration. And again, there is a definite gap between the 2 phases. So these sounds are only abnormal if heard further away from the main airways. We also try to look for any adventitious sounds. So any added sounds like wheezing, crackles. So wheezing is a continuous musical prolonged sound, adventitious sound. So it's prolonged because like if you kind of draw it, it would be like dashes in time. And this is usually expiratory, but you could also hear it during inspiration. And this indicates the narrowing of the airways. So there's 2 main types. So there's wheeze and there's rhonchi. So a wheeze is like, it's high pitched with hissing quality. And rhonchi is kind of lower in pitch with a snoring quality. Crackles, on the other hand, are intermittent. They're brief, so if you draw them, it will be like dots in time instead of dashes in time. And so they're intermittent, they're non-musical, they're brief. And again, there's 2 types. So there's fine and then there's coarse crackles. Fine crackles are usually higher in pitch, so it's usually heard when patients have congestive heart failure, fibrosis, pulmonary edema. And coarse crackles, they're like lower in pitch, and they're usually heard when patients have COPD or lung abscess or even bronchiectasis. So crackles actually happen because of the alveolar collapse during expiration. And we hear crackles mainly during inspiration because during inspiration, those collapsed airway, they abruptly open due to the rapid entry of air during inspiration, thus creating that cracking sound. Another adventitious breath sound is called pleural rub. So pleural rub, it's like a harsh grating sound. These sounds are usually best heard at the lower anterior chest or the lateral chest. So this usually happens because of the movement of inflamed pleural surfaces against each other. So if we identify any abnormal or adventitious breath sounds, we need to assess transmitted voice sounds. So these include egophony, bronchophony, and whispered pectoriloquy. Egophony is when you ask the patient to say E, so like in beat, so E. So what you do is you ask the patient, can you please say E when you feel my stethoscope touch your chest. The normal finding would be we would hear the sound E through our stethoscope, and the abnormal finding would be the fact that that sound would be changed to a more nasal A sound. Okay, and then bronchophony is when we ask the patient to say 99. So you could say this to a patient by saying, when you feel my stethoscope touch your skin, can you please say 99? So the normal finding would be the sound that we hear through the stethoscope would be like muffled and indistinct and not very clear. The abnormal finding would be that the sounds would be clear, distinct. So whispered pectoriloquy is kind of similar. So we ask the patient to whisper 99 when they feel our stethoscope touch their skin. And the normal finding would be the sounds are going to be faint, indistinct, if any, because they're whispering 99. The abnormal sounds would be the sounds would be distinct and clear. So that's the end of the posterior chest examination, and then we move on to the anterior chest. So this can be done when the patient is lying supine with their arms abducted to the side, or you could do this when they're sitting on an examination bed, for example. So patients with breathing problems, like patients with COPD, it's probably best to sit them up instead of like lie them down, because that might be uncomfortable for them, especially if the bed is quite flat. So it's the same sequence. So we start with inspection. Again, we look for in any asymmetries, any deformities in the chest, any like signs that they're having difficulty in breathing, any retraction, use of accessory muscles and things like that. And then we move on to palpation. For palpation, again, we look for three things. First thing, we palpate in the anterior chest 4 areas generally. So 1, 2, 3, 4. Again, for pain or tenderness. And then we go on to assess the chest expansion. So we put our thumbs along the costal margin, and we ask them to take a deep breath in and out, and we should see that movement, this kind of movement. And here we're assessing for symmetry, and we're also assessing the extent, the range of the movement. So the final thing for palpation is tactile fremitus, like what we did on the posterior chest. So you use the ulnar surface of your hand and you ask the patient to say 99. So 99, 99, 99, and 99. And I've described, what you should expect to see. So if there's an increase in tactile fremitus, then it indicates consolidation of the lung. And if there's a decrease in tactile fremitus, then that might indicate hyperinflation. So like for patients with COPD, for instance. So the next in the sequence is percussion. So like what we did in the posterior chest, we percuss in like a ladder pattern. So we start here, then there, and then like that. But we're doing it in the anterior chest this time. Normal lungs are resonant. Any changes, for instance, like dullness, might indicate abnormal lung density, and this can point towards many different pathologies like atelectasis, lobar pneumonia, even tumor or any mass that's growing in the lung. And if there is generalized hyperresonance, then this might point towards obstructive lung diseases like COPD, because usually it's due to the hyperinflation of the lung. Last but not the least is auscultation. So we basically did the same thing as we did with the posterior chest. So first we listen to the patient breathing in and out. So we ask them to breathe with their mouths open, to eliminate any abnormal sounds that might be generated through breathing through a blocked nose. And again, it's important to have that stethoscope directly touching the skin. Again, we look for any abnormal breath sounds and any adventitious breath sounds. If we hear any abnormal sounds, then we assess transmitted voice sounds. So like what we did again with the posterior chest, we assess for egophony, bronchophony, and whispered pectoriloquy.